So thank you. It's a pleasure to be here, coming from UNC and chatting before we started. Realized I had to mention that coming from the home of the Tar Heels, who won the NCAA championship this year, after just barely not winning it last year. But I want to go ahead and talk about radiation therapy in gastric cancer. But I want to start off by talking about what in the world is radiation therapy, really? Everyone knows what surgery is. You take a knife and you cut stuff out. And people have a better understanding of chemotherapy. You put something in the body, either by pills or by IVs, and something magic happens to the cancer. But radiation therapy, for most people, if you haven't experienced it, is very much of a black box. And there we go. So radiation therapy, and I'll show you some of the technical stuff in a moment, kills tumor cells by a number of mechanisms, but the primary one is that it produces damage to the DNA within the cell. So you put radiation in, and it actually damages that DNA, and it prevents that cell from dividing indefinitely. And so the cell eventually tries to divide, and it dies because it's really not capable of going on. It's been damaged. What it does not do is kill cells by burning them. It's not heat. It's not a burn in any sense of the word. It is really a biological effect on the DNA of the cell. And I figured this would be an appropriate analogy, that it's really in many ways very similar to sunlight. And sunlight is a form of radiation that comes down. It's not what we call ionizing radiation, but sunlight also produces damage. And the reason you get a sunburn is not because there's so much heat in it, it's because that sun is producing damage on your skin. And long term actually can produce other problems like skin cancers. And so this is really a schematic of showing what that means. The radiation comes in, that coiled point in the middle is your DNA, and it disrupts that DNA. And when it does that, the cell oftentimes can't repair that, and the cell may die. In many ways, this is similar to what happens with chemotherapy. And for some situations, it's not exactly the same, but many chemotherapy drugs actually act very much like radiation does. But when you use radiation or chemotherapy, how does it really kill tumors? Well, this is really an issue and a study in probabilities. It is a study that when you irradiate a cell or a tumor, there's a certain likelihood that any cell is going to be killed. And similarly, there's a certain likelihood that the tumor overall will be killed. But it's probability. And we're never talking about certainties. We're talking about low probabilities and high probabilities. You have billions of cells within a malignant tumor that you can see. And you have to get rid of all of those that may divide indefinitely. Some of those cells in the tumors won't divide forever. They're sort of already effectively dead. And so we're really trying to improve the chance of controlling these tumors. And you have to give enough radiation or enough chemotherapy to maximize the chance of that happening. But as Dr. Ilsen was saying, you also have to respect the patient and the tolerance of the patient to whatever that treatment is. Does radiation damage normal cells? Yep, it sure does. As does, I would say, chemotherapy. The reason you get side effects from radiation treatments or chemotherapy treatments is because the radiation or the chemotherapy is producing the same type of injury in the normal cells in your body as it is producing within the tumor cells in your body. The difference is that many normal cells have some excellent protective mechanisms to repair some of the damage produced by the radiation or the chemotherapy, so the recovery is often better in the normal tissues than it is within the tumor. But again, not always, and that's why at times when you give these treatments, you have to stop the treatment because the normal tissues are not recovering nearly as well. And this really drives a lot of what we do clinically in taking care of patients. And as I mentioned, sun produces sun damage, and the sun outside today produces a sunburn. In response to that, the body will be doing two things. Some of the cells will be trying to repair themselves, and at the same time, the body is changing is producing more of the normal cells to replace the cells that have been damaged from the radiation, be it sun radiation or radiation treatments. And so these are really similar processes. And think of what happens in a sunburn after you've been outside. That's similar to what's happening in the body when you get treated with the radiation or chemotherapy. And this is just another schematic. This is the DNA, the coil that I showed before. The radiation, many times chemotherapy, damages those strands of DNA, and in some situations that can be repaired, and in some situations not. So we talk about radiation. Well, what is it? How do you actually get it? Well, you get radiation when someone takes a diagnostic X-ray, and you have an X-ray tube, and it comes down, and it aims at what you want to take a picture of, and then you have an X-ray plate to see what happens. Well, with radiation treatments, it's a little bit similar in that we have a machine, as is shown in this slide, and at the top, these are actually linear accelerators. They produce very high energy X-rays. It actually produces electrons that make X-rays, and that is directed at the tumor the same way an X-ray picture is directed at it. And actually, let me just go back. And so when a patient comes in to be treated, they basically will lie down on a couch. That machine will be aimed at them in a way that I'll describe in a few minutes. And the treatment may take 1 or 2 minutes, depends on the details of what's happening. And you get up, and it's no different immediately after treatment as what you might feel after a diagnostic X-ray. So when do you actually use radiation therapy in cancer treatment? Well, it can be used in a variety of ways, and sometimes these are mixed up a little bit. It can be used for cure of a radiation tumor, of a tumor, just by giving enough radiation to destroy the tumor. And we do that. I'll go over some examples of that. And sometimes we use some drugs to make the tumors more sensitive to the radiation treatments, what we call radiation sensitizing chemotherapy. And that's trying to treat the main tumor mass. But we also sometimes treat it in conjunction with surgery, before or after surgery, because the surgery is really good for taking out the lump of the central tumor. But where surgery fails in the area where they're operating is because there are fingers of tumor that are going out, which the surgeon can't see. And despite the best operation you might try to do, you can't get out all of those fingers. Because this is an exercise in probability, radiation does a better job at controlling those little fingerlets than it often does for the big lump of mass. And so it is often combined with surgery. And we use radiation a lot for many, many cancers for relief of symptoms from a tumor mass. Tumor in the bone, tumor in the lung, and elsewhere, where we may not be getting rid of the tumor entirely, but we can direct a radiation beam right at where the problem is and relieve symptoms. And that's a very important part of what we do as radiation oncologists. Well, what are just some examples, putting aside the gastric cancer world alone, of how we use this? Well, and these are only examples. There are many more to these and many more subtleties. But for tumors of the prostate, for a lot of tumors of the mouth and of the throat, radiation therapy can be used alone very effectively to totally destroy the tumor. In tumors that are called sarcomas in the extremities, in the soft tissues of the extremities, we very commonly use radiation before or after surgery to get rid of those fingers of tumors that might remain after surgery. For tumors of the esophagus, and the area right between the junction between the esophagus and the stomach, we'll very often use radiation therapy and chemotherapy preoperatively, before surgery, in order to allow better control of those fingerlets. And this is something that is very commonly done right now for these tumors, what we call the GE junction, the gastroesophageal junction. Sometimes you can't tell whether these are really stomach cancers or they're esophageal cancers, and so they're just called GE junction tumors. But radiation with chemotherapy is often used preoperatively and sometimes alone and not without surgery. You've already heard Dr. Ilsen a little bit that after surgery, for selected stomach cancers, radiation therapy can be used with chemotherapy to get rid of those tumors in the region of the stomach. Tumors of the uterine cervix or anal canal are very commonly treated with radiation and chemotherapy alone without any surgery. And I mentioned also the issue of relieving pain from tumor spread to bone, or relieving symptoms from tumors that spread to the brain. So there are a wide variety of ways in which we use this treatment. How about side effects of treatment? Well, side effects of radiation are entirely dependent on the site being treated. This is very different. This is much more like surgery than it is like chemotherapy in a sense, because surgery, you get symptoms from what you did right where it is. You took something out, you take the stomach out, you have trouble eating. And radiation, likewise, produces symptoms related to the site that is being irradiated. And so you can get skin reactions at times and get a sunburn-like reaction, just like from the sun. Very commonly, radiation causes some fatigue. If you treat areas in the head and neck area, you can get mouth sores. If you treat in the abdomen, if you treat a stomach and the region of the stomach, especially before surgery, not after surgery, you can have significant problems with nausea. Lower down in the belly, you might have problems with diarrhea and the like. So if you hear that someone had radiation and had some symptoms and you're going to get radiation, your symptoms may be entirely different than what they have because it relates to the site that is being treated. And most of these side effects are temporary, but certainly some of these symptoms can persist long term. So a little more about how radiation therapy is delivered, and there are a lot of different words that I will explain a little bit to you as we go on. And you may hear these if you see your physician. We're going to use 3D conformal radiation therapy, or intensity modulated radiation therapy, or image-guided radiation therapy, or stereotactic body radiation therapy, or brachytherapy. And these are really technical issues trying to accomplish what radiation oncologists spend a lot of time doing, which is directing the radiation dose as much as possible only to the area where we want it. If you treat it areas where you don't need to treat, you only get problems. You only get symptoms from the treatment, and you don't get benefit. So it's really important that we define what it is we need to treat and then try to limit the radiation beam to accomplish that. So I showed you a picture of a sort of a standard garden variety radiation therapy accelerator. This is a much fancier type of a machine. And this one at the top, you can see the radiation beam would come straight down. There's that piece that comes off on top. And on the bottom there's actually an imager. So you can actually take a picture of what you're treating. And off to the side, both on the right and the left, there's actually an X-ray tube, more of a diagnostic X-ray tube. So you can take pictures before treatment, and sometimes we can actually do CT scans on these machines to define very precisely where we're treating, and then adjust the exact location of the radiation beam to conform to where therapy needs to be delivered. And so these technical issues become really important. The same way for a surgeon, whether you do a robotic procedure or something else, and you heard all of the differences, it's a matter of figuring out what works best in that particular situation. So most standard radiation therapy are given daily, Monday through Friday, something in the range of 4 to 6 weeks for the disease we're talking about here. Treatments only take 15 to 20 minutes. They don't hurt, something like a long X-ray picture. But the multiple treatments, the reason we give so many treatments, because this allows for the repair of some of the normal tissue. but still allows adequate killing of the tumor. Now, there's one example that I will mention at the end where we don't do that at all because we're not worried about the normal tissues that we need to treat. But this allows for the normal body recovery and allows the patient to tolerate a dose that would really cause major problems if we gave it all at once. For all of the techniques, we have to define the target, the area that we need to treat. And the radiation oncologist will look at the CT scan or an MRI scan or a PET scan, the pathology, the operative note, and I'm sure Dr. Parikh would appreciate the fact that we actually read their operative notes to figure out what they did. Sometimes I call the surgeon and say, hey, I don't understand. Tell me a little bit more so we can figure out how best to design these fields. We adjust for uncertainty in designing these fields and they do treatment plans based on all of this above information. Very importantly, this is all in the context of understanding the natural history of these diseases, how they spread, where they spread, and just as Dr. Parikh will do a different operation for a tumor up around the gastroesophageal junction versus one that's at the other end of the stomach, we do radiation differently for those because the spread patterns of those diseases are different. All gastric cancer is not the same, even in the spread pattern. And these machines, it's not just a big rectangle of radiation that comes out. They're shaped so that the treatment areas conform to what we need to treat. And we design radiation fields that come in from many different directions that are really focused on what we wish to do. And this is an example looking up into the machine. If you look where the beam was coming out and you're looking straight up, these are what are called multi-leaf collimators. And these can all of those areas that we call leaflets can be adjusted to conform to the exact shape of what we wish to treat. And this is really critical in defining, therefore, what we need to do. So let's talk a little bit more specifically about radiation therapy and gastric cancer. And the rationale for using radiation therapy is that tumor can recur in the surgical bed because of this microscopic disease left at the time of surgery. Sometimes gross disease, but usually it's not gross disease. It's not something you can see, but it's something that where you know there's risk of disease. And sometimes the pathologist will tell you that there's something left behind, even though the surgeon thought everything was hunky-dory. And radiation is aimed at the area where the tumor was originally, whereas chemotherapy is something that is more broadly attacking tumor cells throughout the body. But we need to understand exactly what those areas are. And it is critical that we minimize the radiation dose to the sensitive tissues of the body. And for stomach cancer, we need to worry about things such as the liver, the kidneys, the spinal cord. For tumors that are higher up, the heart, the lung, the small bowel, and all of these can be damaged from the radiation, and we try very hard to avoid that. And so we go through a process. I'm going to go through some slides that I wish the pointer worked or I could use it, but you see in the middle we've outlined areas that we wish to treat, and then the areas things that coming in from the side of those multi-leaf collimator that I showed before, and conforming the shape of the field to what we wish to treat, and also in what we wish not to treat. And then, I guess I mentioned this already, and oftentimes we're very concerned about lymph node disease in gastric cancer, because there can be residual lymph nodes and tumor where the lymph nodes were. And radiation therapy may have one of its more important roles in getting rid of tumor and residual lymph nodes. So I have a few slides like this. Let me try to explain this to you without a pointer, which is hard. But this is what we call a color wash. If you look, these are 4 images of the same patient at different CT scan levels within the body. Some are higher up, some are going down. And so you're looking like you cut across the patient and looking at that area. In the back, you see the spine. And the area where it's sort of red and blue are the areas where the various radiation beams are converging from different directions on the areas that we wish to treat. And you can, there are areas, the kidney, the spinal cord are all outlined. And this is what we would call a 3D conformal radiation therapy, which is very standard, but it is not the most advanced approach that we use nowadays. And then we calculate within the computer. We actually make 3D models of these patients on the computer and then calculate radiation doses. And then we make plots. And what these plots are showing how much dose the tumor, how much dose various normal tissues get. That red line at the top is the tumor, so we want that at the top so it gets high dose. And the more you go to the left and to the bottom, the better it is, the less dose that normal tissue is getting. Green is the liver, it's getting a somewhat higher dose, and you see the kidneys are in yellow. And we can, by looking at metrics such as this, define what dose normal tissues are getting, whether those remain within acceptable limits. This is a tumor of a somewhat different location, and the technique is now a little more complicated. The radiation beam is coming in from more directions, but the whole idea is still to get the radiation dose to conform to what we wish to treat. And for each patient is individual. It's not the same volume for each patient that we treat. And you come up with these different curves, these dose-volume histogram curves, and different approaches that I won't go into more, both in the interest of time, and I don't think there's any need to do it. We know that radiation therapy for the tumors located at the gastroesophageal junction, combined with chemotherapy, is a very effective method of treating patients prior to surgical resection. And it's an approach that's very commonly used nowadays for these gastroesophageal junction tumors. It's important also to realize that the incidence, you heard a little bit about the incidence of gastric cancer over the years, and what's happened epidemiologically is quite interesting, because esophageal cancers used to be mostly more in the upper esophagus, up towards the neck, and things have changed, so esophageal cancers are moving nearer the gastroesophageal junction, they're moving down. And gastric cancers that used to be mostly a disease in the middle of the stomach or the end of the stomach have moved up towards the esophagus. So basically the stomach cancers have moved up towards the esophagus esophagus cancers have moved down towards the stomach, and this is now a really common type of cancer, while the overall incidence of gastric cancer has decreased dramatically. It was mentioned 100 years ago, lung cancer was a rare disease. Gastric cancer was far and away the most common cause of cancer death in the United States. The epidemiology has changed significantly. Radiation therapy with chemotherapy also, radiation with chemotherapy sometimes will be curative when used alone for these tumors of the gastroesophageal junction, but that is generally not our preference, but occasionally we do that when a patient can't tolerate surgery. And this is an example of a radiation field that's somewhat different for a gastroesophageal junction tumor, because the tumor extends more up higher, because we're concerned about different pattern of spread in this disease. And I want to do that. So I think that this slide and the next one are my last two. I think they're out of sync on the Spanish side, so if you can look over on the English side, that would be good. So the other approach that I want to mention is the use of what's called stereotactic body radiation therapy. And this is something that in gastric cancer, esophageal cancer, its role is very much unclear, but this is delivery of radiation therapy in just 1 to 3 treatments, sometimes 5 treatments, to really totally destroy almost everything at that site. So we sometimes use this for a limited area of tumor spread to the liver, to the lung, sometimes to the lymph nodes. If there's one area where the tumor has spread, we will sometimes use this. These are very, very tightly localized fields, much smaller than what I was showing you in the slides before. Its role in gastric cancer is not clear, but its role is increasing dramatically in a number of other diseases that we see. However, for all of the treatments to the stomach, we need to be careful of issues of nutrition. Surgery, radiation therapy, and chemotherapy lessens absorption capacity, decrease reservoir function, monitoring weight, multiple small feedings. You have to be concerned. B12 absorption was mentioned. There are also issues of calcium absorption. People get osteoporotic after this. And iron absorption is very much decreased after these approaches. And so these great attention needs to be paid to nutrition. For all of these, when we're thinking of treating gastric cancer, we need the best combination of surgery, chemotherapy, radiation therapy, and perhaps immunotherapy as we move forward to maximize both our local and systemic control. At the same time, minimize both acute and long-term toxicity. And we all have the same goals of doing the best for our patients, their families, and the future generations. And this latter is really important to me, because as a few people in this room may know, almost 22 years ago, I was diagnosed with gastric cancer. And I had multiple nodes positive. Treatments are somewhat different then, but I did have a gastrectomy at that point. I'm thin, not necessarily because I'm a runner or anything like that. I'm thin because my body doesn't absorb nutrients as very well. I still eat a lot. I still eat often, and it's hard. We're trying to do all the things we can as physicians for ourselves, but also our families and our future generations. I was here speaking at this meeting, I'm not sure, maybe 4 or 5 years ago, and I showed a slide. I'm not sure it's the same slide, but so these are my grandchildren, my 6 grandsons. And when I was diagnosed, I had little expectation that I would ever live to see them. They've grown up, we're living for them, and to be able to see them grow is really an honor. Thank you.
Thank you.